Welcome to Advanced Patient Care, the exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of patient care through dynamic insights, practical clinic tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in ophthalmology and optometry. Our mission is clear: empower eye care providers with the knowledge and tools needed to deliver exceptional patient care. The Advanced Patient Care podcast is dedicated to elevating our craft, one episode at a time.
Hey guys, welcome back. I'm Mitch Eibach, an optometrist with Vance Thompson Vision in Sioux Falls, South Dakota, and I'm thrilled to be joined by one of my friends, my colleagues, and a world-class optometrist in Dr. Brooke Messer, who practices in Fargo, North Dakota. I'm excited to have some time together, really in preparation, getting ready for World Keratoconus Day coming up on November 10th. And we're going to talk about keratoconus and really this progressive corneal condition that really leads to fairly irreversible vision loss for our patients. There's some exciting diagnostic technologies. There is treatments that are tried and true, as well as treatments that are hopefully coming soon in the pipeline. And so, Brooke, I'm excited to jump in and have this discussion with you.
Same. Happy to be here with you, Mitch, and happy Keratoconus Day to everyone joining us.
Yeah. So I want to just kind of zoom out to start. Brooke, if you'll just give us kind of the 1,000-foot view of keratoconus, what this means for patients, some of the symptoms that they can experience.
Yeah, so thankfully the awareness of keratoconus and what it means for our patients has really been growing with the efforts that organizations like the National Keratoconus Foundation have been, putting out there to educate not only patients but also providers. So you may be familiar with keratoconus. It's a bilateral corneal thinning condition that causes distortion of the corneal shape, and those corneal distortions significantly impact patients' vision. Sometimes it's, it obviously starts mild and then in some cases can progress to a very severe corneal distortion where patients have, significantly decreased visual acuity. Others kind of stall out in more mild, moderate stages and they, fail to get diagnosed. And so I think the biggest change in how I have looked at keratoconus in the last decade or so is not just about the cornea and that, they can't wear glasses, so we can put them in a gas permeable contact lens. It's more about like the weight of keratoconus and its diagnosis, and that this is a lifelong condition and patients get diagnosed fairly early in their life. And so that does weigh a lot on our patients' overall well-being. And so I've started bringing that into how I look at KC2 as well. And how can I make patients think about their eyes a little less? How can I make them feel a little bit better about their long-term eye health and overall well-being? Whether it's, raising their kids, advancing in their careers, going to school, and those types of things. So now I think our 10,000-foot view of keratoconus includes not only the disease itself, but also making sure that our actions around managing their disease are going to allow the patient to proceed through their life with minimal impact from disease progression.
Yeah, that's absolutely great. I think quality of life is so important with many different just overall kind of systemic conditions, ocular conditions as well. And I think in keratoconus, we're really starting to focus in more on quality of life and how do we help patients achieve the best quality of life. There's a great study that I'm sure you're familiar with that compares the quality of life and more mental burden on a patient with keratoconus being very similar to moderate stage dry macular degeneration as far as how it affects some of the things they can and can't do. And actually the numbers are very close to approaching severe stage. And so how do we help these patients not only with their ocular health, but kind of holistically as well, I think is great.
And again, like patients get macular degeneration when they're older, where keratoconus happens when they're younger. And so it's almost like, time with the condition is where that like mental burden really weighs on a young person, knowing that this is something I have to deal with for the rest of my life. And so again, like early intervention and detection has really become a focus, not only of the organizations that help keratoconus patients, but also in clinics like ours as well.
Yeah. And so keratoconus is classified as a rarely diagnosed condition, and really our treatment approaches are best deployed. We have the best visual for sure outcome in patients when we're able to deploy these treatment approaches earlier in the disease, before a patient has significant warping and thinning to the cornea, before a patient is symptomatic, for sure before a patient's lost best corrected visual acuity. But diagnosis is tricky because patients don't walk in the door and say, hey doc, I think I might have keratoconus. And so what are some of the clues and tricks that you have for having the suspicion of keratoconus? And then we'll talk about how we go into more of a definitive diagnosis.
Yeah, so the suspicions for patients with keratoconus when they're walking in, it would be mostly young patients that are complaining about their vision quality. I always say that 25-year-olds shouldn't be complaining about driving at night. So that's one where if I have a young patient that is otherwise normal, they have a clear lens, clear vitreous, healthy retina, they shouldn't be complaining about their vision quality. Other things that I ask about are allergies. Patients with keratoconus tend to be more symptomatic with their allergies. They tend to have lots of allergies, so they are rubbing those eyes, which we know is not great for patients who are at risk for developing keratoconus. They tend to have stuffy noses, coughs, all those types of things. And so it's kind of what they call an atopic type syndrome, where they have lots of skin issues as well. And so those are all things that kind of help me put the clinical picture together, that I have somebody who's complaining about their vision. I'm seeing them rubbing their eyes, in the clinic. And then certainly, the examination findings, like some asymmetry on their topography, which we're going to dive into in a little bit. Maybe some unclear refractive error. I just can't quite get that crisp 20/20 that I'm looking for, doing a refraction. Those are all things that would spark me to say, hey, we probably need additional workups on this patient.
Yes, I'm thinking through the patient history. A patient who has a familial history, so a first-degree family member of keratoconus, I want to know more. A patient who is a patient who has Down syndrome, it's another patient who I want to dive deeper on. And then a patient with connective tissue disorders, maybe it's Ehlers-Danlos syndrome, maybe it's mitral valve prolapse, history, some of the systemic conditions that have lines that run into kind of keratoconus incidence going up. As we're starting our entrance testing or some of the pre-testing that patients are doing, oftentimes just an autorefract.
Mm-hmm.
A patient who's having increasing amounts of myopia, increasing amounts of astigmatism. And then finally, once we get that patient behind the phoropter, we're doing forced choice, which is better, one or two. I think you alluded to this, but really young, healthy patients should be able to achieve good quality vision and good acuity. And so if you have a patient who's uncorrectable to 20/20 or at minimum kind of 20/25, we want to understand the why there. And so
Yeah.
those are some of the ones that I'm using. I think autokeratometry or having keratometry values, the curvature of the cornea is important as well. Once you start to really get away from average or normal, which is about 43 or 43 and a half diopters, once you're at 47, 48, 49, something's off here. And those are kind of the clues that warrant, in our practice, going to more advanced diagnostic testing. And so you touched on topography. I know we really love tomography as well, epithelial mapping, which maybe I can touch on, but why don't you give us a start on topography and tomography, how you're using that to make more of a definitive diagnosis?
Yeah, so topographer is a good screener. Sometimes it can miss like the earliest of keratoconus findings that a tomographer could maybe pick up. But again, in a primary care optometry setting, even a school screening type setting, topographer is great to have. When I see, and a topographer measures the front of the cornea, where tomography can measure the front and the back of the cornea. So when I'm looking at the front of the cornea findings on a topography, I think one of the things that tends to show up even earlier than, the classic inferior superior asymmetry or that inferior steepening that we see with keratoconus are skewed axes. And so I like to click on the function on the topographer that highlights the primary meridians of the refractive or the corneal power, basically. And I like to make it, sometimes it only highlights the central three, but if you have the opportunity to turn it on to go all the way out to the limbus, you'll see that rather than having those 90-degree meridians that we do with most normal corneas, we start to get those skewed axes, or what we call like a sloppy snowman, so that top axes or bottom half of the vertical axis starts to skew. And so seeing axes that are not primary meridians that are not 90 degrees apart, to me, that tends to show up before we really see that inferior steepening. So that's something that I look for that's something that I would look for if I only had topography. Now, moving into tomography, where we can see the front and the back of the cornea, that does the functions of a topographer because it images the front, but then it also tells us about the back of the cornea. And one of the definitions, updated definitions of keratoconus is posterior bowing. So we need posterior changes, we need posterior elevation in order to diagnose KC. And when you don't image the back of the cornea, you can't officially really diagnose it without it being probably of moderate level KC on a topographer. And that's where, again, we have to lean on those clues like the nighttime complaints, the changes in astigmatism or changes in autorefraction findings over the course of a patient's life to then say, oh, this looks a little funny. My topography may be normal, but the numbers aren't making sense. I better get them a tomographer. And so it's helpful to look at those trends over time so that the tomography can try and pick it up as early as possible. Topography also tells us global pachymetry. So we can see the thickness of the cornea from the thinnest point all the way out to the periphery. And tomographers can identify if that central point is thinner than average, and the way that it goes from thinnest to thickest parts of the cornea, if that happens at a more rapid rate. And so that tells us about the corneal thickness across the entire surface, and if there's atypical thinning, and that would also help us identify early KC. So tomography is so valuable in detecting and managing keratoconus. I really can't imagine practicing without it.
Yeah. So I think one of the call to actions there is if you have a patient where the clues are adding up that this could be keratoconus, or you do a topography in your practice and you say, gosh, this looks like maybe really early keratoconus, but I don't definitively know that. I think the call to action is refer that patient on for a baseline tomography, because having the ability to see both the front of the cornea and the back of the cornea, even if it's not keratoconus, if it's not great, now we have at least a baseline scan that we can refer back to. I'll touch on just epithelial mapping. Mapping just the front skin layer, the epithelium of the cornea, has been really helpful as well to try to catch some of these subclinical keratoconus cases. Maybe even before there's topographic changes, you can start to see thinning of the epithelium over the cone. And so I think that's a robust discussion on diagnosis, and that's kind of step number one. Now we got to go to step number two, which is maintaining best corrected visual acuity for these patients and talking about some of the treatment approaches in the surgical space that we have. And then maybe we'll touch on contact lenses. And so I think in the surgical or procedural treatment space for keratoconus, there's treatments that are really focused on preventing further progression, stopping the bulging of the cone, and then we have treatments that are maybe meant to help patients see better. And so I'll let you take one of those and I'll take the other. You get to pick.
So when it comes to preventing progression, we have the FDA-approved corneal cross-linking procedure, and that's where we soak the cornea in a medicine that's primarily riboflavin. So we saturate the cornea with that medication, and then we expose that cornea to a specific wavelength with a lighted device. And those two things, the riboflavin plus the light, builds these collagen bonds between the corneal fibers to strengthen them so that keratoconus doesn't progress. One of the great things about this technology is that we recently hit the 10-year FDA pivotal trial mark, and a bunch of those patients went through and had their corneas analyzed, and well over 90% of patients with keratoconus were stable at 10 years. So we know that it's a lock-in procedure. Patients can really kind of again go back to that mental load of just taking that burden off, knowing that, hey, this treatment that I'm having done is efficacious, and it's proven that it helps lock in their disease. The current FDA-approved protocol includes removing the epithelium, but we're approaching perhaps FDA approval of being able to leave the epithelium on, which will be amazing in that we can do the treatments with the eyes closer together. Patients recover faster, less discomfort, quicker visual recovery. So a lot of good to look at for there. So we participated in the clinical trials with good outcomes and saw those endpoints. So we're excited about the potential to be able to offer that to patients, hopefully sometime in 2026.
Yeah, exciting. And so that was kind of the bucket of treatments that are really meant to preserve the corneal condition that it's in now. Keep this patient from further progressing or losing fairly irreversible vision loss. The two technologies or procedural treatments that I'll touch on for trying to enhance or improve a patient's best corrected visual acuity, so maybe still wearing glasses or contacts, or try to get them some functional vision, maybe without glasses and contacts, optical devices, is CTAC. So this is a procedure where we're using human corneal tissue, using it to reshape the cornea in these kind of arc-like segments, corneal tissue addition keratoplasty. And so a procedure really trying to make wearing glasses easier for our patients. The analogy would be to intrastromal corneal ring segments or Intacs, which was using acrylic kind of half moon or arcs to reshape the cornea. Now we're doing that with more human corneal tissue with CTAC. And then laser vision correction, which previously was maybe a hot button topic. I think we're starting to have more success with doing this topography guided, trying to use more of the patient's shape of the cornea and then normalize it a little bit with the laser. This is very, very different from doing corneal refractive surgery on a patient who has a pristine corneal shape. This is maybe trying to gain visual function, but can give some improvements in vision to our patients as well. And then let's move to specialty contact lenses. Brooke, not only are you currently being awarded the North Dakota Optometrist of the Year, so awesome.
Thank you.
Congratulations for that. Also nationally known for fitting specialty contact lenses. And so give me kind of 3 to 4 pearls on specialty contacts, and then we'll wrap up.
Sure. Yeah. So with, if we're going to do scleral lenses on a patient with KC, which to be honest, I really love that. I love not interacting with the apex of the cone. I don't want to do anything to that epithelium because it's already thin. So I really like using scleral lenses on patients with keratoconus. Not to say that I don't like corneal GPs. I just think there's a different population for that. With sclerals, I think the biggest thing is making sure that you have the right lens diameter. Patients who have moderate KC or advanced KC, they tend to have sensitive eyes. And so providers want to like shift to a smaller diameter because they think it'll be easier for the patient to get into their eyes. But when the diameter is too small, you actually end up compressing on the limbus and you can cause some corneal neovascularization and things like that. So again, we need to really stick cornea size is what you need to analyze and then match it up with the right lens diameter. So that's tip number 1. When I do keratoconus refits, they're almost always in the wrong diameter of lens and it's almost always too small. The second one would be allowing for proper settling. Patients who have keratoconus, they tend to have a bit more edema or periodic edema or conjunctival swelling, if you would, chemosis. And so their vault is a little bit less predictable. So I would just give yourself an extra 50 to 100 microns in your sagittal depth of the lens to allow for those times when, hey, this eye is a little bit more inflamed, a little bit more allergic. We're going to protect the apex of that cone so that if the lens does settle more than average, we're protecting that corneal apex. And then lastly would be to understand the impact of higher order aberrations that are residual after a scleral lens is on. Being able to measure higher order aberrations or refer the patient in to have them at least analyzed so that if you have a patient who you think you should be able to get to 20/20 in a GP lens and you can't quite get them there, especially in KC, it's likely due to their higher order aberrations, and there are technologies out there now that then correct it, and it is amazing. Patients do so well. And so those are my 3 things, just really protecting that apex with the right size lens and the right depth. And then we now have things that we can go beyond and above and beyond what we previously been able to do with the optics of a scleral lens.
Awesome. Well, this has been impactful. It's been robust. And I think I can kind of wrap it all up by saying in 2025, as we go into 2026, keratoconus management, our mantra should really be diagnose early. So try to get the diagnosis earlier on these patients. And then we want to, once we can show progression, ultimately get them cross-linked. We want to stabilize the cornea, keep this patient from continuing to progress, current state, epithelium off cross-linking. Hopefully we're going to have epithelium on, and then that will again make a change for our patients, hopefully improve quality of life and maybe less anxiety of going into that procedure. And then ultimately step number 3 is to help patients see better, rehabilitate the vision. That's really finishing the journey or continuing on what that patient came in for. Ultimately, that's what patients care about. And so with that, I'll close by saying happy World Keratoconus Day to all optometrists and ophthalmologists. I think we all have keratoconic patients in our practices, and so it's really a day for us to focus in on this condition and also celebrate some of the wins that we've had in the space. Thank you guys for listening.
Thanks, everyone.
Thank you for tuning in to Advanced Patient Care, the exclusive podcast by Vance Thompson Vision. Want to learn more? Schedule a personalized mini fellowship at one of our clinics where you can gain hands-on experience and real-world applications tailored to your practice. For more resources and information, visit vancethompsonvision.com/OD. Let's continue advancing patient care together, one episode, one innovation, and one patient at a time.